My name is Peter Blythe. I'm the Director of Nursing for the Trust Development Authority, and I'm pleased to be hosting and introducing this film on nurse staffing. This is an important topic. It's important for patients primarily, but it's also important for staff. Staff who work in the NHS in our sector and more broadly in the NHS need to know that we're working hard collectively to get nurse staffing right so that they can practice the way they want to, but also in the interest of patients to make sure the patients receive good care. So this film brings together some good practice from a number of our organisations across mental health, community and acute providers, and it's setting out good practice, what the people at the sharp end are doing about nurse staffing and the support that the TDA is offering by way of spreading good practice, but also supporting nurse and finance directors and boards more generally in trying to get this agenda right for patients, right for staff and right for organisations generally.
The aim of the NICE guidelines on staffing is to help trusts have the right number of nurses at any point in time to deliver care for the patients that are there. The hospital board should be taking an active interest in nurse staffing. So there's an organisational responsibility, and there are also responsibilities for the nurses in charge of care on a day-to-day basis to make sure that they are confident that they've got the right number of nurses available and that they know how to ask for additional help if that's needed.
Well, if you think that nurses actually provide 80% of the care provided to any patient in hospital over the 24-hour period, we're the individuals that are there all of the time, and to get that nurse staffing right means that your patient gets the treatment that they need and the experience is a good one, and that's why it's so important. It always has been and it always will be.
It's not all just about numbers, it's about how the whole team looks. So for example, if you work on a stroke unit, how are your physios and occupational therapists contributing to the team? What's the skill mix on the team, and how well supported and well trained are your unregistered workforce?
A lot of the nursing care was based on historical values, and so the actual numbers of nurses were based on historical levels for a totally different patient population. We needed to look at making best use of resources, moving staff around to where they needed to be, making sure that we had the right skill at the right time in the right place.
I think prior to the new process, I think it was very much an ad hoc and a bit of intuition really about how we managed our ward. We didn't really go into any great detail about our dependency of our patients at any given time.
So within my division, every morning I will take a look at the nurse staffing. I'll make sure that we've got the right number of staff on. I use the Safe Staffing database in order to be able to do that, and at a glance I can see at any time where there may be issues with the nurse staffing, or where indeed nurse staffing is perfectly okay, to give us an assurance that nurse staffing and patient care is safe.
So we've used the Safer Nursing Care tool, and that's been really helpful for us in terms of identifying the number of people that we need on our wards. Was it a big surprise? No. Are we talking about enormous numbers? Not really. We're probably talking about 2 or 3 extra members per ward area, so not huge numbers. There's quite a lot of evidence to suggest that if you've got a ward with lots of bays on it, it's useful to have a registered nurse in each of those bays. So my most recent review has really reflected that.
At one level, actually, and I'd have to say this in fairness, it adds to the complexity of the amount of data, but actually it adds, I think, incredibly relevant data to the mix. And the one thing for me explicitly that it does is it takes us out of the area of anecdote or assuming we know the answer, or somebody said to me last week, and puts us in the place where we look at hard data, and from that we start to create real knowledge and intelligence.
I'd like the guideline to have 2 main impacts on patient care. The first is on the outcomes for the patients. So for instance, they might have fewer falls, they might have fewer pressure ulcers. And the second thing is that I'd like patients to have a better experience, because by putting proper staffing in place, there should be more time for nurses to talk to patients and to listen to their concerns, and overall patient satisfaction will improve.
It's so much better. It's more recovery focused. You feel listened to. If staffing levels are very low, then it impacts on your health and well-being on the ward. It also impacts on staff as well. I'm so thankful, because without them I wouldn't be here.
What this framework and the Safer Staffing Guidance gives us is an opportunity to share the evidence that we gather by looking at each individual patient and then working out from that what the establishment of each ward should be. And I have to take a report to my board every month to show them whether we've met those nursing staffing levels or not. And what I said to our board was, you give me this staffing, us as a hospital, if we've got our nurse staffing right, everything else will fall into place, and it does.
A big part of my role is working with the chief nurse, particularly around safe staffing levels around the numbers of nurses we have on wards. There's obviously a financial implication around that, but it's about making sure that the case we put to the board demonstrates the impact both in terms of the finances, but also the impact in terms of quality and effectiveness, and most importantly, the patient outcome and the patient experience. One of the biggest challenges for any trust in terms of any staffing investment is that business case approach that says, okay, we're making a fairly big investment, how do we demonstrate that return? And one of the things we've done in this trust is to look at some of those non-financial benefits. So we've looked at ward by ward, looked at indicators such as complaints, falls, infections rates. They themselves have financial impacts for the trust, and that makes the case stand up, and it also demonstrates the fact that by having substantive nurses in post, we improve the patient care and the patient outcome.
By using an effective tool and really using the evidence, it was much easier for the argument, and in fact the board paper that I took had very little discussion around it because it was very easy for everybody to see that we'd been through a rigorous process and we hadn't just, you know, plucked these figures out of the air really. So I think that they actually said, this is really easy, we know what you want, we understand why you want it, and now we need to think about how we're going to afford to pay for it.
We were flying a bit blind really at board level, in the sense that we had good professionals at the board level who gave us, I think, reassurance as opposed to firm assurance about whether our nurse staffing levels were correct and whether they matched the dynamic way in which patient dependency and demands placed on our nursing staff change. I think that all changed with the review, and what we now have at the board level is real information that enables us to look each month, actually, by ward in our organisation about the staffing levels we have, and those are updated regularly around patient dependency. So I think the board has much more assurance now as opposed to reassurance around nurse staffing levels, and that's terrific.
The way in which we collect data has developed over time, from initially a paper-based system to a developed live IT-based system which can be accessed by ward staff and anyone else who's got access to it. And that system allows now, after some months in development, to have quite coherent reports around not only numerical data in terms of numbers, but it also highlights impact on patient experience and on safety.
The systems that we use are very simple. Every night the staffing numbers are collected by the senior nurses who work across the trust on a 24/7 basis. They're inputted into the database. It will probably take them a couple of minutes to do that. It's information that's known at ward level already. And then first thing in the morning, my job is to look very quickly. It'll take me a 5-minute job to look at my database, to check my nurse staffing, and then to make decisions if I need to around making sure that areas are staffed appropriately if they need to be supported at all.
We look at the data on a regular basis, so we've now moved to an electronic collection of data, and in that collection of data it's not just about numbers. We are asking what episodes of care are being missed and what episodes of staff time are being missed. So subtle things such as supervision, reflective practice, the supervision students, are things that can go when you're really tight on your staff numbers. So your staff numbers might look okay, but those things disappear, and they've got effects that are probably more medium to long term rather than the immediate term.
We talk about evidence-based practice in nursing, we talk about evidence-based practice in medicine. Collecting the information and sharing what we know as nurses helps us to argue and to rationalise what we need to care for our patients. So data is really important to us. I never realised how important it was until we started to use it in this way. And the most important role that we've got in our team now is our data analyst, who helps us look at all of this information in a meaningful way and look at all of our nursing indicators in a meaningful way, and every ward knows how they're doing.
We really aimed to help empower nurses, and it's really important that when it's likely that there aren't sufficient nurses available, those nurses are empowered and supported by the hospital managers to call for more help, because there clearly is going to be variation in the numbers of nurses that are needed. So that ability for a nurse to put the hand up and say, I need some more support now, is really key.
Having this system ensures that we can deliver an assurance that we're providing safe care, and we know that safe care is provided by having the correct number of staff on the ward. And the skill mix is important to know, because some wards on a day-to-day basis or a shift-by-shift basis may have a lower acuity of patients than other wards, but it is essential to enable us to look across the wards, make sure that those wards are safely staffed, and very quickly mitigate the risk if they're not.
We talk to the individual nurse that's in charge of that ward, and the nurses are providing care on that ward to say, well, okay, we've got a sickness here. We thought you'd need 4 qualified nurses on here today. Do you still need that? Because the dependency and the need of your patients might have changed. If you do, then we have to look to see how we can support that. And what we do is we look whether we can get a bank shift in, or we can move somebody from another ward who actually has less dependent patients than this ward today. So it's done, as I say, on a shift-by-shift basis, and we mitigate the fact that somebody hasn't turned up for work today by doing those things. And we've got 50 odd wards in this hospital. There is usually someone who can help if we need them to.
I do feel better empowered as a result of that, because I know that as an organisation now my voice is being heard, before where I hadn't, maybe before it was difficult for that voice to be heard. So I feel now that I can escalate it in an appropriate manner. We have a proper standing operating procedure now, so that I know, and I have the confidence that my team, if I'm not here, can follow that same escalation process to make sure my ward is safely staffed.
Nurse recruitment is absolutely crucial to getting all of this right. We can work out how many nurses we need, we can work out how many we need every day, every shift. We've got to get those nurses in place. We've got to get the nurses with the right skills as well. We've recruited over 750 nurses in the last 13, 14 months here. We've got a very low vacancy rate. We know we're lucky to have that. But I think the one thing that's made the difference is us doing it for ourselves.
From our overall perspective, we've done a number of analysis to say how much have we spent over the years in terms of agency and overtime. And we have been spending significant sums, and we realise those are a premium. So we've had a conscious decision to say, where possible, let's recruit substantive members of staff.
So in Walsall, we've looked at recruiting nurses in a slightly different way. So it struck me that the group of people that we particularly wanted to recruit were Band 5 staff nurses. They're predominantly within an age range of about 20 to 35. And on reflecting on that, most people of that age group do most of their investigation and research online. So it seemed sensible to me that we should set up an internet type recruitment campaign. Now, I don't understand how Facebook works and I don't understand how Twitter works, but I thought that that was a really good way of looking at things. So the comms team worked with me, and we had an external company who came in and ran a whole campaign for us over a month. As a result of that campaign, we recruited, I think it was 63 new registered nurses in just over a 3-month period. So I think that had a significant impact and was much better than we'd ever experienced before through NHS jobs or any other recruitment campaign. The actual cost for recruiting each individual staff nurse is significantly less than we would have spent doing it by the normal routes.
We're very clear with our workforce plans. We regularly recruit, and we don't have problems in Merseyside recruiting for mental health nurses, and we don't have problems recruiting for healthcare assistants, so we're able to attract high calibre staff. However, one of the things that we've been doing is the people we recruit from are from the bank. So actually that depletes the bank, so we continually have to replenish bank staff as we take people on board from the bank to be permanent. And the other thing that we've started to do is look forward 2 or 3 years and what our needs are. So while we don't have a recruitment problem now, we do anticipate in about 2.5 years that we'll start to hit significant challenges due to the ageing workforce. So we've been working with Health Education England to look at how we might be able to utilise widening access approaches to support healthcare assistants to become assistant practitioners and assistant practitioners to become registered nurses. So it's a really good way of building on the expertise that we have in-house to send staff off on these courses to come back, and usually very loyal to the organisation and stay. So it's a win-win situation, but you do need a fair bit of advanced planning. You can't do that overnight. It takes 2 to 3 years.
What I would say to other organisations who are embarking on this journey is look at the whole range of metrics. Some of them you can easily put financial benefits to. Others you just need to do a bit of work. And if you look at things like complaints, you look at things like falls, you look at things like infection rates, you look at things like VTE assessments, etc. And you will know ward by ward where you have hotspots. If you also equate that to maybe some of the staffing issues, because you don't have the numbers of substantive staff and you're having to rely on overtime and agency, etc. I think there's a challenge to say as a board, if this is about quality of care, you may need to invest. You can make the business case stack up by looking at the benefits of doing that from a financial perspective, but also the non-financial perspective.
I know a number of organisations are very nervous about the safe staffing and how we would assess safe staffing. And I can give reassurance that we look at everything. We use indicators as exactly that, indicators for potential risk. We absolutely understand that there may be occasions where, for the best will in the world, you can't get your staffing levels right, and we will take account of that. What I'm more concerned about are those areas where they've been chronically understaffed for a long time with little action taken. So if you're able to show us that you've got good risk mitigation, you've got good risk escalation plans in place, that you're able to assess demand and capacity, and that your staffing plans are absolutely based on patient need, then that's what we're looking for.
I think it's almost inconceivable, frankly, to be an organisation that says it wants to be patient-centred and then not understand what those critical units called your staff. You know, if you're applying them right, if it is efficient and effective, if you're really driving the sorts of outcomes that I know that every board wants to produce, but this puts you in, frankly, into a very transparent position of having to understand the nuts and bolts of your operations in a really different way.
It's not a choice between quality and finances, it's an and. It's about providing a quality service and providing a sustainable financial organisation. And that is the trick for us all, and that's what we've got to deliver. So I don't see it as a choice, I see it as us supporting the delivery of that patient care.
The thing that collecting that data has done for us, not just on staffing levels, but on our nursing indicators, so the quality of care that we provide, is that we've started to use that information to monitor what we do rather than measure. So we don't measure for performance, we monitor to improve, and we want to be the best hospital, or in the top 20% of hospitals in the country, if not further afield than that. So we've used that information in a completely different way to what we had before.
This is a hospital that's been able to recruit 742 extra nurses in the last 18 months. People are being drawn to this hospital based around the evidence that the data is providing, and the fact that this is a fantastic place to come to be a nurse with huge opportunities. And I genuinely believe that the publication of the data is resulting in people wanting to come here because they want to come to places that are well staffed, well led, and you're well supported. And that's got to be what the rest of the NHS needs to do.
For every nurse, what I would say is we now have a process that means we can look at our patients as we always have done, but with a framework that tells us exactly what that patient's needs are and what we need to care for them in an appropriate way. That means our patients get the best care possible, and that's the most important thing.
I hope you found the film useful and instructive. It's important that we recognise the good work that's going on in all NHS trusts, but we particularly picked out 4 trusts to share their experience. And I'd like to thank those organisations, both the nurse director that led that work, but also the staff who delivered the work. The TDA recognises how challenging and difficult this agenda is, which is why we want to continue to support you in getting it right, both for staff, but more crucially for patients.